Hello, today I will be talking about aortic dissection. Aortic dissection is a medical emergency. The aorta is the largest artery in the body. It terminates at L4, where it becomes the left and right common iliac artery. The aorta is an elastic artery, and like other elastic arteries, its wall is made up of three important structures. These are the following: the tunica intima, which is the innermost layer and lies closest to the blood, the tunica media, which is the thickest part and contains muscles, and the tunica adventitia, which is the outermost layer and contains the blood vessels which supply the aorta itself. In aortic dissection, the innermost layer tears. Aortic dissection is commonly associated with two main conditions: Marfan's disease and other elastic tissue disorders, and hypertension or high blood pressure. This association is very common and is seen in 80% of patients with aortic dissection. Aortic dissection is commonly classified as whether the ascending aorta is involved or not. In terms of the anatomy of the aorta, there are four key parts: the ascending aorta and the arch of the aorta, the descending aorta, and finally the abdominal aorta. If we delve closer into the arch of the aorta, we see there are three main branches, from right to left: the brachiocephalic trunk, which divides into the right common or the right subclavian artery and the right common carotid artery. Then the left common carotid artery in the middle and the left subclavian artery. The two main types of aortic dissections depend on if there is involvement of the ascending aorta. Type A will involve the ascending aorta, and we can think of A for ascending. There may or may not be involvement of the descending aorta. Type B involves the descending aorta only, i.e. the third part of the aorta, and this has important prognostic factors. In terms of presentation, aortic dissection will present with chest pain, central in nature, which radiates to the back, giving interscapular back pain. What are the key tests in aortic dissection? Well, there's a full blood count, an U&E, group and cross match, D-dimer, which can rule out the differential of PE, and troponins, as acute coronary syndrome and aortic dissections commonly coexist. The signs of aortic dissection include unequal radial or brachial pulses and hypertension. On chest X-ray, you will see a wide mediastinum, and an ECG may show an inferior myocardial infarction if the right coronary artery is involved. The differentials for aortic dissection include PE, acute coronary syndromes, and thoracic vertebral pathology. Aortic dissection is treated differently depending on whether it is type A or type B. Type A will require an emergency surgery repair. In contrast, type B is managed medically. You will need to achieve a low blood pressure in both types. This is a systolic blood pressure of less than 100. This can be achieved by IV infusions of labetalol or GTN spray. Some key things to consider: if you are thinking of dissection, an urgent CT scan of the aorta is required. This will show a false lumen and a true lumen. If it is type A, the patient should be rushed to the nearest cardiothoracic centre for imminent surgery, and moreover, they should have antihypertensives to lower their blood pressure. Aortic dissection has a very poor prognosis and has an 80% mortality in the first 48 hours.